My name is Linda-Gail Bekker. I'm the International Co-Chair of AIDS 2018, the President of the International AIDS Society. I'm delighted to welcome you all to Amsterdam for this meeting and to TB 2018. This is a project of the International AIDS Society working in partnership with Union, with Stop TB, with USAID to say that, it is high time that the TB community and the HIV community do come closer together, since that certainly is the case with our patients, and we do need to be having more joint meetings like this. I'm delighted that the Union meeting will be at The Hague later this year, and there'll be a reciprocation there. So fantastic that we are here. So Gavin, you're here. I'm also going to call up Maureen, Abdulai, and Elvi to come up immediately. If you are all here, please do. Welcome. So my panel, so don't panic if you had many prevention questions, because the panel is also on prevention. And so the way we're going to do this is I'm going to ask individuals to give short, sharp responses. Who are we missing? To give as many short, sharp responses as we can to a few questions that I'm going to pose, and then we will allow more questions from the audience. So, and I am going to draw this to a close shortly around 11 o'clock, because that way we'll be getting closer back on time. So, prevention, always very important. I think in the HIV world, we started with prevention. We had no other options. We then became, I think, very focused on treatment, and rightly so. We had many, many lives to save. There has been a huge emphasis on the 90-90-90 again, rightly so. There is value in treatment as prevention, but we in the HIV world have come around to recognize primary prevention cannot be left off. It is really important that if we want to bring epidemics under control, that these two parameters have to exist together. We have to treat those who are diseased or infected, and we have to prevent, as far as possible, those who are vulnerable but not in that situation. And that is an approach to any infectious disease. And today, TB and HIV really sit squarely as major public health burdens. And so, Gavin, I'm going to start with you. I know we have had a lot of detail in the last wonderful set of talks, but I'm going to ask you to summarize, contextualize biomedical prevention therapy within a broader prevention scope for us, if you don't mind.
Thanks, Linda-Gail. So obviously, among people living with HIV, antiretroviral therapy is the mainstay. It's absolutely essential. But ARVs, as Dick pointed out, by itself is not adequate. We need additional interventions to help further reduce and protect against TB. Dick has already outlined some of the preventive therapy regimens that we currently have available, starting with isoniazid given for periods of 6, 9, 36 or lifelong. We now have the rifamycin-based regimens with the 3 months of isoniazid and rifampicin, or 4 months of rifampicin alone, and then the 3 months of high-dose weekly isoniazid and rifapentine, or the daily for 1 month of isoniazid and rifapentine. And then for MDR-TB exposed individuals with presumed MDR-TB infection, to use a fluoroquinolone with either levo or moxifloxacin, with or without ethionamide or ethambutol. TB infection, of course, is really essential, particularly in our primary healthcare clinics, where patients with undiagnosed TB seek care. And so we really need to make sure that in all our facilities we have TB infection control. But similarly in other congregate settings, such as in prisons and in mines. And also we may consider this within public health spaces. Public spaces. Then with respect to TB vaccines, we have an effective vaccine to prevent severe forms of TB in children, We don't yet have an effective vaccine for adolescents and adults, and we think that's the target group we should be targeting to prevent ongoing transmission. But some exciting new developments that have occurred, and so we're hoping that this field will move forward. Then we mustn't forget that treatment of TB disease is treatment as prevention. So there's now emerging evidence that as soon as people are started on effective treatment, they rapidly become uninfectious, and it's literally within hours. And so really finding these TB cases and getting them onto effective treatment is a high priority. And then, of course, case finding to find the undiagnosed cases that are continuing to transmit is clearly important. And that is part of the prevention package. So ultimately, prevention is an integration of a comprehensive test, find, test, treat, and prevent. Thank you, Linda-Gail.
Thanks, Gavin. And we'll come back to that. But I'm now going to turn to more of a sort of community voice here. And Abdulai, you come to us from Sierra Leone. Welcome. What is your sense of the community understanding of prevention as a concept? And I think we've done really well about you must, if you have symptoms of disease, you must turn up, you must get treated. There's been a good emphasis on that. What is your sense of community responses to prevention?
Thank you very much. Community has a big role to play when it comes to prevention. As a TB survivor, I think I went through a lot of horrible situations during the time I was taking my treatment, and I suffered catastrophic cost. But I also think issues around access to quality TB treatment is very important. And we should also recognize the fact that most of people who are affected with TB are highly vulnerable. I mean, some of them are very poor. I mean, so it will be very, very challenging for them to pay high cost of TB treatment. For example, if somebody is walking for like 20 to 25 kilometers to access the TB services, then that poses a challenge. And that's why we are also experiencing loss to follow-up cases. We also missing a lot of cases, in the TB response. So as a community, we have a role to play. One, to make sure that we have the enable environment by creating policies to support the empowerment of patients, and also making sure that drugs are available. Because one of the things we are also experiencing in some of the countries is the drug stockout. So this is something we have to make sure that drugs need to be available at the facility, and the patient should be able to access the drugs at the appropriate time. And many times, most of these facilities don't have the adequate equipment. Like, for example, if a facility does not have a scale to, weigh or measure the weight of a patient, the tendency for that patient to be misdiagnosed, will be very high. So that is why community engagement or involvement is very important in the TB response. And then also community is also contributing to community TB strengthening. I mean, when we talk about service delivery, we need to involve the community as well. Like what we are doing in Sierra Leone, we are doing community-based monitoring, looking at what the TB health clinics are doing, following up on whether they are actually following the national TB guidelines. So if you are not following the national TB guidelines, you raise a red flag that that facility needs to really follow the national TB guidelines. And then I also think that when we don't support the country in quality TB service delivery, then it will be a problem. So when we conduct our community-based monitoring, we also make sure we collect information around stigma, collect information around gender-related issues, as well as human rights. And we create the opportunity whereby we also disseminate this information to key stakeholders, like having the National Accountability Forum, where we discuss some of these issues to address them. And so that is why it's important. And also setting up TB support group that contributes to treatment adherence, counseling, and also social support to empower TB patients.
Thanks, Abdulai. I'm going to give Elvi a chance just to sort of chime in here. I think that activism is really very important and sort of generating community demand for good quality services and being aware of what is available, particularly on the prevention side. So I'm going to ask you, from your experience, where are we failing and what could we be doing more in terms of creating that demand from civil society and our patients?
Thank you. I'm going to highlight a little bit about the importance of the community involvement and the CSO involvement in TB. I will emphasize in the importance of the community engagement. I will take these words, and speak on behalf of Indonesia because we are living in a very, difficult geographical situation. No matter how much, the government, try to reach all the islands, all the people, it will never enough. That's the community, as the key, and as the important partner, equal partner for the government, to prevent TB. That's something I think that the governments never realize, or the stakeholder, the important stakeholder, never realize the importance of the community. Their voice need to be heard. How to do that? That's something that we never, give ear from the community. We put them as a receiver only, but we never heard from them. So, and then we have to admit also that, prevention is not something important yet, or not a priority in every country. This is proved by, there's no record. There's no proper record yet how the country, run the prevention. It's mostly like, more treatment. But I think it's better to prevent than to treat when it's too late. And I think, and what is the successful, you asked about the successful things, I'm working with the people. I'm working with the people with TB and involved directly with the community. I work, islands from islands, and then to see that the community, to hear from them, is the key, to make the program, to make the prevention program and the treatment program success. When we come to the community and say that, let's do this together, you have rights to speak. You have rights, to get the best treatment. You have rights, to be healed. You have rights to the health access. And as an activist, it's our part, CSO, to speak up on behalf of them. We need to bring this issue to the higher level. We need to bring together the district leader, the national leader, NTP. We need to bring the community voice. Mm-hmm. They need to do something on that. It is very sad to see, I will be very concerned about this. We are sitting here, all of us, talking about policy and procedures, how to do TB and HIV. Mm. But do we really find out a very good, way how to make sure those policy, how the community knows, their rights. So that's something I think that we need to concern about.
Great. Thank you so much, Elvi. I'm going to come back to you, Gavin, and just, now literally asking you in a minute or so succinctly, where do you think the main research priorities are in terms of prevention of TB?
All right. Well, maybe if I can just preface that by other limitations and gaps, we do need political leadership. We can't have political leadership without funding. So a call to Global Fund, to PEPFAR, to please put your money where your mouth is. Countries need dedicated funding to scale up preventive therapy. Otherwise, it's not going to happen regardless of political leadership. The price of rifapentine remains very high, and we need to find ways of reducing that by driving volumes and by bringing in generic manufacturers. We've seen interactions between rifapentine and rifampicin with the new antiretrovirals, particularly dolutegravir and to a lesser extent TAF. And we need the safety and PK studies of rifapentine and rifampicin with dolutegravir and TAF in HIV-infected adults as well as in children and in pregnant women. The length of treatment, as Dick said, 1 month is great, but we can do better. And so we need to find and use regimens that may get us down to 2 weeks. The 1HP is only been evaluated in HIV-infected individuals, but we need the data to support it in HIV-uninfected individuals, pregnant women, and in children. Adherence remains a challenge, and so we need to support adherence because unless people complete their treatment, it's less likely to be effective. And so what is the role of these electronic dose monitors that are being evaluated? And then we need to develop long-acting preparation. So instead of taking a month of isoniazid preventive therapy, if we had long-acting formulations that are potentially injectable, it may mean one or two injections and you're done, and then the adherence problem disappears. And this has been led by Sue Swindles from the ACTG. And sorry, now I've just lost my notes.
Well, I'll insert one, is that clearly with the recent happy information around, again, rejuvenation of TB vaccine research.
Correct.
Certainly we can insert that while you look for your notes.
Right, so now
Did you
I've got
find
it.
them? Okay.
So then in terms, we also need predictive tests for developing TB, so using these gene signatures, as well as tests of cure, so that we know how to best use them. And then we've heard that we don't need tests for starting people with HIV or in children less than 5. But what about all household contacts, which is now the recommendation? And a study that we did to precede the big Phoenix trial we're starting with in 10 countries, spanning from Latin America, Sub-Saharan Africa, India, and Southeast Asia, showed that in households of TB, MDR TB cases, so we know that kids less than 5 and HIV-infected individuals require treatment anyway, so they are one of the risk groups. But then amongst the remainder, in this big trial, 80% had evidence of TB infection. So the vast majority of household contacts have an indication for preventive therapy. So why are we requiring a test of infection in that group?
Yeah.
It doesn't make sense in terms of programmatic scale-up. And then in terms of special populations, we need this adequate dose of rifapentine in children less than 2, so that we need to do the PK studies for, and pregnant women, as I mentioned. Yeah, so
Great.
that's basically the list of
That's
priorities.
quite a shopping list, Jose, to take to the high-level meeting there. But while the panel's here, I'm going to actually be able to allow 2 questions. So here's another 2 that you can, if you can get to the microphones. And I'm going to ask both, whilst you are doing that, Abdulai and Elvi, literally in one sentence, what would you like to hear at the high-level meeting later this year? What do you, from community, what would you like the people who will be taking And if you can just keep that to one sentence. Abdulai, what would you like to hear there?
Well, I must say we need to make TB more sexy.
Yeah.
And so once we make it more sexy, then we'll be able to address most of the challenges we're facing. Thank you.
Right. Thank you. We may need to unpack that a little bit more, but Elvi.
Yeah, for me, I would say that it involves community. It involves community in policy making and also in making national plan in every country.
Great. Thank you. I see a question there. Can you, one question, please, and no preamble, to quote Lele. Yeah, I think it's on.
Okay, thank you very much for all the presentation. Mine is a comment. I just want to see by raise of hand how many NTP managers are in the room.
How many what?
NTP managers, National TB Control Program managers in the room. Okay, we have two, because what is going on now is that we are paying a price of what we have advised the NTPs to do many years ago, especially those coming from high-burden countries. Oh, LTBI is not your priority. Just find the missing patient, find the cases first, treat them, put them on treatment. So we are actually paying a price for what we have done 20 years ago. And we collectively now have to come up with another strategy to create this mind shift in the minds of the NTP managers. Every NTP manager developing a national strategic plan or global fund application or USID, LTBI is the last option. It's not a priority high there. So we need to come back with another advice to them to reprioritize or give a balance that caring and preventing are equally important, because it was our mistake in the past. Thank you.
Well, thank you. Yes, can you go to the microphone, please? And keep it very short, if you don't mind. Apologies for...
I just wanted to say, HIV 15, 20 years ago was not sexy. It was a taboo to talk about. It was a horrible disease. It was frightening. But we all stood up and decided to fight. It was not sexy. So I think the word sexy, not about you, my brother. I've heard it in so many places, that TB is not sexy. HIV was never sexy. But it was killing. We were afraid. That's how we moved as a world.
Okay, thank you for that comment. I'm going to just now again give the panel just last words around, if you could, in a moment, and I think we've heard some of it, but just to sum this up, if you could in a magical moment get one thing to put prevention squarely back on them, or get it on the map, what would that one thing be? What do you think we really, really need to focus on? Gavin, I'll start with you again, just because you're closest.
So I think we need a model country. I'm hoping it will be South Africa that will show the world how to do this.
Sorry,
listening, Jürgen.
and Jürgen, as we didn't have the implementing policymaker person, Maureen, on this, so I do feel that your sector was not well represented on this panel. But a shout out to the people who are trying to get these programs off the ground around the world, and recognize that we didn't. But thank you, and yes, thank you, Gavin. What about you, Abdulai?
We need to reach the unreached, finding the missing people.
So leave no one behind. I think there are some slogans that easily cross from the HIV sector to the TB sector. And finally, you, Elvi.
Well, I think Abdullah already stole my statement, but again, about prevention. It is better to prevent than to cure.
Right. Well, thank you so much. I think that's a great statement to end this particular panel on. I think there are some lessons, and we speak about this. I'm now going to unashamedly call out the IAS Lancet Commission that was launched on Thursday, where we really do say more and more, HIV cannot be in a silo, TB cannot be in a silo, sexual reproductive health cannot. These are areas where we have to work together for the common cause and for the common good. And so more and more, I think the lessons we've learned in HIV need to be applied to TB and vice versa. And these two fields need to come together so that we do move towards better prevention and inevitably better control of these two epidemics. I want to thank so much a panel who stepped up, spoke quickly, got the ideas out there quickly, and I'm sure there will be continued opportunity for engagement. Thanks so much, everyone.